Okay, guys. So this lecture is about the transition from primary to permanent dentition and the complications which may arise during this transition. This is the part one of this lecture. I have divided this lecture into two parts. So first of all, let's see what is primary dentition. Primary dentition, which is also known as deciduous or baby teeth, refers to the first set of teeth that erupt in a child's mouth. These are 20 teeth in total with 10 in each jaw, that is upper and lower. They play a crucial role in chewing, speech development, and guiding the permanent teeth into their proper positions. Primarily, teeth typically erupt between 6 months and 3 years of age and are gradually replaced by permanent teeth between the ages of 6 years, and 12 years. Mixed dentition is the stage or is the phase of development when both primary and permanent teeth are present in the mouth at the same time. And we call it early mixed dentition and late mixed dentition, depending upon the number of permanent teeth and deciduous teeth are present at that time. So this transitional phase typically occurs between the ages of 6. So at this age, when the permanent teeth they start erupting, we call it early mixed dentition. And when it is about to be like over, we call it towards the age of 10 to 12, we call it late mixed dentition. So marking the period when baby teeth are gradually replaced by the permanent teeth. Permanent dentition refers to the set of teeth that humans develop as they replace their primary or baby teeth. It typically begins at around age 6 and is completed around age 12 to 13, with the final wisdom teeth, which appear later, maybe up to 21 years, or even in some of the cases, either they are missing or they are impacted and they don't erupt. So permanent dentition consists of 32 teeth, including the wisdom teeth, with 16 in each jaw, maxilla, and mandible. Well, if we look at the average calcification and eruption times of the deciduous teeth, this I have taken from Laura Mitchell's book of orthodontics. Calcification commences weeks in utero and eruption in months for the primary dentition. Central incisors 12 to 16 weeks in utero, and eruption in months is 6 to 7 months. Lateral incisors 13 to 16 weeks in utero and 7 to 8 months for the eruption. Canines 15 to 18 weeks in utero and 18 to 20 months for eruption in months. First molars 14 to 17 weeks in utero for the calcification and 12 to 15 months for eruption. Second molars 16 to 23 weeks in utero and 24 to 36 months for the eruption. Keep in mind that roots of the deciduous teeth it completes earlier, like within 1 to 1.5 years of eruption. Whereas average calcification and eruption times of the permanent teeth, calcification commences in months, mandibular central incisors 3 to 4 months, and eruption 6 to 7 years. Mandibular lateral incisors 3 to 4 months, and eruption is 7 to 8 years. Mandibular canines 4 to 5 months, and eruption is 9 to 10 years. Mandibular first premolars 21 to 24 months for the calcification, and eruption is 10 to 12 years. Mandibular second premolars 27 to 30 months, and eruption is 11 to 12 years. Mandibular first molars and the maxillary first molars, they usually gets their calcification commences at about the same time when the child is born, at around birth time. Well, mandibular first molars, their eruption timing is 5 to 6 years, and the mandibular second molar 30 to 36 years, 30 to 36 months for the calcification commencement, and 12 to 13 years for the eruption. Then mandibular third molars 96 to 120 months for the calcification commencement and 17 to 25 years for the eruption. And as I told you, in some of the cases, they are either absent, missing, or they don't erupt at all, they are impacted. Maxillary central incisors 3 to 4 months, same time for the calcification commencement, and they erupt at the age of 7 to 8 years. Maxillary lateral incisors 10 to 12 months, and they erupt at 8 to 9 years. Maxillary canines 4 to 5 months for the calcification, and eruption time is 11 to 12 months. Maxillary first premolars 18 to 21 months for the calcification and 10 to 11 years for the eruption. Maxillary second premolars 24 to 27 months for the calcification and 10 to 12 years for the eruption. Maxillary first molars around birth, and eruption is almost 5 to 6 years. Maxillary second molars 30 to 36 months for the calcification commencement, and they erupt at 12 to 13 years of age. Maxillary third molars, their calcification starts at between like 84 to 108 months, and eruption is 17 to 25 years, which I told you earlier that they would be missing, they would be not erupting at all, or they would be impacted. Here, keep in mind for the permanent teeth, after the teeth are erupted and they reach the occlusion, it takes almost 2 to 3 years for the root completion after the eruption. Well, we are discussing about the transition from primary to permanent dentition. Eruption deciduous teeth usually starts around 6 months of age and is completed around 3 years of age. The deciduous incisors, they erupt upright and they are spaced like this. These spaces are known as physiological spaces, the spaces which are present between the deciduous incisors. A lack of spacing strongly suggests that the permanent successors would be crowded. That is the clinical significance of physiological spaces. If they are present, then we don't have to worry at this time about the crowding. But if they are absent, then from now we should start getting worried that probably permanent teeth would be crowded. Overbite reduces throughout the primary dentition until the incisors are edge to edge, which we can see over here, which can contribute to marked attrition. And we can see that they are attritioned as well. Around age 6, either first permanent molars or permanent central incisors, which one? Lower one. They start erupting, and they mark the start of mixed dentition phase. The lower labial segment teeth erupt before their counterparts in the upper arch and develop lingual to their predecessors. Permanent incisors, they start erupting lingual to the deciduous incisors. It is usual that there is some crowding of the permanent lower incisors as they erupt, but it is reduced when there will be intercanine growth. We can see slight imbrication over here. As a result, the lower incisors often erupt slightly lingually placed and or rotated, but usually they get aligned spontaneously if space becomes available. If the arch is inherently crowded, then this space shortage will not going to be resolved even with the intercanine distance when it will be increased during the growth. Well, transition from the primary to the permanent dentition, we are discussing the upper permanent incisors also develop lingual to their predecessors. Additional space is gained to accommodate their greater width because they erupt into a wider arc and are more proclined than the primary incisors. If the arch is intrinsically crowded, the lateral incisors will not be able to move labially following a eruption of the central incisors, and therefore they may erupt palatal to the arch. ugly duckling stage. The ugly duckling stage, also known as the ugly duckling phase, is a common and normal stage in the dental development of children, typically occurring around ages 7 to 11 years old. It refers to the temporary, often unappealing appearance of a child's smile as their permanent maxillary, upper central, and lateral incisors erupt. Clinical presentation would be midline diastema, which we can see over here. A prominent gap often appears between the two newly erupted upper central incisors. Flared lateral incisors, the upper lateral incisors, due to the pressure from the erupting canines above them, may appear to flare outwards or distally. So in your OSCE, they can give you a mixed dentition case models, and where you will be seeing that their central incisors would be having diastema and their lateral incisors would be flared. So outward or distally. They may ask you if like it is unusual. If the diastema is not too big, then it is not unusual. But if it is too big, then check for the frenum. Maybe the frenum is attached very close to the incisive papilla, and if they will ask you how we will be sure that it is due to the incisive papilla, tell them that we will invert the lip and look at the incisive papilla. If the incisive papilla is going to get blanched, it means that the diastema, the abnormal diastema, is due to low attached frenum. Well, the other reason I'm going to explain otherwise normally why this diastema, which is not going to be too big, is going to be there. Another reason why this diastema would be present, tell them if the frenum is not attached too close to the papilla, incisive papilla, there would be a chance that maybe some mesiodent would be present, or there could be chances of some cyst over there. So we will go for an X-ray in that case. So I just told you about the midline diastema and flared lateral incisors. Well, the ugly duckling appearance is usually self-correcting phenomenon. As the permanent maxillary canines erupt later, around ages 11 to 12, they push against the roots of the lateral incisors. That is why this ugly, we can see it over here, the canines, they are pushing against the lateral incisors, and that is why they are tilted, and we have this space over here. So this pressure in turn helps to push the central incisors together, often closing the midline diastema and aligning the incisors. The angulation of the roots and crowns also normalizes as the canines come in. Clinical significance of the ugly duckling stage. Reassurance of parents. It is very important for dentists and orthodontists to recognize this stage and reassure parents that it is a normal part of the development and usually resolves on its own. Unnecessary orthodontic intervention should be avoided during this phase. Monitoring. While often self-correcting, it's still important for a dentist or orthodontist to monitor the child's dental development to ensure that eruption is proceeding normally and to rule out other causes of diastema or malocclusion. For example, supernumerary teeth, missing teeth, large jaw discrepancies, etc., etc. Correction of ugly duckling look. As the canines erupt, the lateral incisors usually upright themselves and the spaces they close. The upper canines develop palatally but migrate labially to come to lie slightly labial and distal to the root apex of the lateral incisors. In normal development, they can be palpated buccally. We call it labial canine bulge from as young as 8 years of age. This is the canine bulge, and an absence of canine bulge means that probably there would be a chance of impacted canine. So the term canine bulge in dentistry typically refers to the prominence in the alveolar bone that is associated with the unerupted permanent canine tooth. This bulge is observed in the maxillary jaw in children, usually around the age of 9 to 12 years, which is the typical eruption period for the permanent maxillary canine. It could be seen in some of the cases in mandible as well, but it is not very pronounced. Significance of this canine bulge, normal development sign. In most cases, the canine bulge is a normal and healthy sign of an impending eruption. It indicates that the canine is developing and moving along its eruption path. Indicator of eruption space, its presence can suggest that there is sufficient space for the canine to erupt. Forewarning of impaction. Conversely, the absence of palpable canine bulge when expected or an unusually located bulge can be an early indicator that the canine might be impacted, unable to erupt normally, or erupting ectopically in an abnormal position. This is why dentists and orthodontists regularly palpate the alveolar ridge in the canine region during routine checkups for children in this age range. Impact on adjacent teeth. Sometimes the pressure from the erupting canine can influence the position of the adjacent teeth, which I just mentioned, contributing to the phenomena which we call ugly duckling stage, where the lateral incisors might flare. Well, palpation for this canine bulge. Dentists routinely palpate the buccal vestibule in the canine region to feel for this bulge as part of their assessment of dental development. Radiographic confirmation, if a bulge is absent or unusually located, radiographic assessment, for example, panoramic x-rays, periapical, even CBCT and occlusal view, and even cone shifting techniques can be performed, often used to confirm the position and eruption path of the canine. Orthodontic planning. For orthodontists, the presence, absence, or unusual location of the canine bulge is a critical piece of information for predicting eruption and planning potential interventions if impaction is likely. Primate spaces. Primate spaces, nature's provision for developing dentition. Primate spaces, which are also known as primate gaps or physiological spaces, are naturally occurring diastemas that are typically found in the primary dentition of children. These spaces are a normal and healthy feature of a developing occlusion, and they play a crucial role in accommodating the larger permanent teeth that will eventually erupt. So where they are located, these spaces are found in specific locations in both the maxillary and mandibular arches. Maxillary arch, the primate spaces, remember their positioning, located between the primary lateral incisors and the primary canine. Primary lateral incisor and the primary canine in maxilla. And distal to the primary canine and mesial to the first deciduous molar in the mandible. Remember these points. An absence of primate space means there would be definitely crowding. There would be definitely crowding. An absence of primate space means that. The presence of primate space is highly significant for these reasons. Accommodation for permanent teeth, permanent incisors, canines, and premolars are considerably larger in mediostidistal width than their primary predecessors. Primate spaces provide crucial extra room in the arches, allowing these larger permanent teeth to erupt into relatively well-aligned positions without severe crowding. Maintaining the arch length, these spaces help maintain the necessary arch length for the eruption of the permanent dentition. Without them, there would be a higher likelihood of significant crowding as the larger permanent teeth emerge. Indication of normal development, the presence of primate spaces is generally considered a good indicator of normal dental development. Their absence or insufficient space can sometimes signal a higher risk of malocclusion, that is crowding, in the permanent dentition. Differential, I just mentioned about that. Differential diagnosis: when a dentist observes spaces in child's primary dentition, recognizing them as physiological primate spaces helps differentiate them from other types of diastemas that might indicate some underlying issues like missing teeth, habits, or supernumerary teeth presence. Leeway space. The combined width of the deciduous canine, first molar and second molar is greater than that of their permanent successors, particularly in the lower arch. The difference in width is called the leeway space and in general is of the order of 1 to 1.5 millimeter in maxilla and 2 to 2.5 millimeter in the mandible on each side, means in each quadrant. Remember this point. This means that if the deciduous buccal segment teeth are retained until their normal exfoliation time, there will be sufficient space for the permanent canine and premolars. The deciduous second molars usually erupt with their distal surfaces flush anteroposteriorly, which we call flush terminal plane. The transition to the stepped class 1 molar relationship occurs during the mixed dentition as a result of differential mandibular growth and or the leeway space. In contrast to the anterior teeth, the permanent canines are larger than the primary canines and the premolars are smaller than the primary teeth they replace. Clinical significance of the leeway space. When the secondary primary molars are lost, the first permanent molars, they move forward mesially relatively rapidly into the leeway space. This decreases both the arch length. This is the arch length. If you remember, I told you about the arch length. We place a line mesial to the first permanent molar and then perpendicular to it in the midline of the arch. This distance, this distance is known as the arch length. And arch circumference touching all the teeth from first permanent molar to the first permanent molar on the other side and touching the buccal cusp and the incisal tips of all the teeth. That is the arch circumference or arch perimeter. So this decreases both arch length and arch circumference, which are related, but they are not the same thing, I told you. Even if incisor crowding is present, the leeway space is normally taken up by mesial movement of the permanent molars. Yes, even the incisors are not going to get any relief with the leeway space. Only first permanent molars are going to move mesially. An opportunity for orthodontic treatment is created at this time because crowding could be relieved by using leeway space if it was maintained. I told you in one of our lectures about the space management and about the serial extraction. Now, we are discussing this transition from primary to permanent dentition. In mixed dentition, occlusal relationships resemble those of the permanent dentition, but the description is different. A flush terminal plane indicates normal primary molar alignment. And what is that? It is an end-to-end relationship of the first permanent molar. We consider it as normal. From here, it could move, either stay end-to-end if there is minimal growth. It may move forward growth of the mandible. It may go into class 1 relationship, or it like half a cusp type of relationship. But if the forward growth of mandible is good, then it will attain class 1 relationship. Mesial step will either stay. Mesial step is, as I told you earlier, mesial step is class 1 relationship. Mesial step, it will stay either as class 1, but if there is a lot of mandibular growth and we call it the actual skeletal class 3 discrepancy, then there would be a chance that it may develop into a class 3 relationship. Remember one important point. Distal step, which is class 2 molar relationship, it will stay class 2 if there is not a lot of growth. Even if there is a growth of mandible, it will still be an end-to-end relationship. It will never be converted into class 1 molar relationship without intervention. And what intervention? At the time of growth, maybe we will go for the functional appliances. So if you are not applying any intervention, it is not going to be like spontaneous correction to class 1 is not going to occur from the distal step. Remember that point. So when it is present, it often reflects a significant skeletal class 3 discrepancy, which I told you, the class 3 relationship. Otherwise, we have only three relationships in the primary dentition most commonly, and the uh, normal one is flush terminal plane. So distal step for class 2 and mesial step for the class 1. Remember these points. So over here we are done with our today's lecture, and inshallah on Saturday morning we will be continuing with its step 2, like part 2.